Hello, everyone. My name is Rebecca Peebles. I'm the Vice President of Adolescent Medicine for Montanito and Affiliates, and I've been in that role full-time since Halloween of last year. And prior to that, I was with the Children's Hospital of Philadelphia, and I still work with their research program. Um, I have been asked to talk about something that's very near and dear to me today, and it is setting target weights. Are we aiming high enough? So without further ado, I'm so thankful that so many of you are here, and I'm gonna keep going. Millie, you'll keep letting people in the waiting room, I'm assuming. Okay. All right, so I have no relevant disclosures, and I'm not speaking of anything unapproved or any commercial products. So just to review, and I know you guys have a whole day of this, but what is an eating disorder? Like, what do we know now in 2024? And we know that these are treatable brain-based illnesses, that they essentially, it's when the brain tricks people into thinking that their body is full when it's actually starving, that they are not hungry when they desperately need food, and that they have energy when their body is truly exhausted and needs rest. They are frequently preceded, so the onset of an eating disorder is frequently preceded by a period of relative malnutrition. And this is often due to benign causes, can be getting mono, getting braces, joining a cross-country team, but anything that creates an energy deficit for people with vulnerable brains. That energy deficit can, if they are neurobiologically vulnerable and genetically vulnerable to eating disorders, then that can make their brain more rigid. And then rather than just catching up the weight naturally a couple weeks later, like many people would, they keep going down a rabbit hole. These are not lifetime movie diseases. I'm probably dating myself with that reference, but I am old and so I will do it. Also, Lifetime Movie Network is still a thing if anyone watches it, but they don't need body image distortion expressed overtly. We now have both cognitive ways where you can just express it overtly, but also just, we can have people express it in their behaviors. So with that, I just want to talk about what we know about body size and health. There's actually a lot less correlation between body size and health than what you may hear in the media. And most important on this slide is that non-surgical weight loss efforts are unsuccessful over 97% of the time. And still healthcare providers will often make the suggestion to eat less, exercise more, and lose weight. Even though in general, people cannot lose weight even over the short term, unless they have an eating disorder. And then once they lose weight, it doesn't stay off. And these are people in higher weight bodies I'm referring to who have been told that they need to. Also important is to know that things like hypertension, hyperlipidemia, insulin resistance, these can be seen in people of all sizes, and they can be improved by changing health behaviors, even if your weight does not change. Another thing that people often don't know is that, and again, despite what you will hear from both scientists and in the media, that you will hear things like, mortality goes up the higher your BMI is. And you can see by this curve, which has been replicated in numerous studies now, that actually the lowest all-cause mortality rate is between the BMI ranges of around 25 to 37 for adults. And despite this, we still have classifications by the CDC where greater than or equal to 25 would be considered overweight, and greater than or equal to 30 would be considered obese. But in fact, grade 1 obesity, and again, I'm going to put that in quotes because I'm not a big fan of the word, leads to no difference in mortality outcomes over time. We also have seen a lot of shifts in the 25 years that I've been in practice in terms of how we think about eating disorders. I think much for the better, but our older paradigms, which hopefully you have not encountered, but they are still practiced sometimes, are that eating disorders are a result of control or boundary issues with this is sort of back from some original work by Hilda Bruch back in the 1960s and 70s. And if you formulate your thoughts about eating disorders as that, then it makes sense that people are eating less or trying to control what they're eating because they feel out of control at home, because they have controlling parents. Again, putting that in quotes because this is not what I believe, but as a result, for many years, we thought that parentectomies would be helpful, where we would have kids leave their home, go for treatment with experts, and we really thought that kids and adults needed to develop insight into their illness, and into why they had their illness, and usually that was around these kinds of paradigms before any improvement could occur. The newer paradigms really consider these as eating disorders as a result of biologic and genetic vulnerability, with, of course, environmental influences. And that parents and family members generally are our best allies in helping people reach recovery. And that we now know that the brain requires nutrition first before insight can occur for the majority of people. That is not to say that if someone is developing insight before they are eating, that we are like closing our ears to it, but we don't really expect people to have super profound thoughts about this until they're eating. So we need to sort of work on that first. And I should say, in the current screen that I'm in, I actually can't see the chat. So I was going to answer things during the talk. But as a result, I'm going to wait till the end, and then I'll go through and go through as many questions as I can. So one sort of item of controversy is where goal weights are commonly disputed are in higher weight patients. So we know that anorexia and all restrictive eating disorders can happen at all sizes, and that they're not at all uncommon in people of larger bodies. So being at higher weight is actually a risk factor for developing anorexia nervosa. And in fact, in all treatment centers that have published on this, about a third of their patients and almost 40% actually presenting for treatment of a restrictive eating disorder have a weight history where their BMI at some point was above the 85th percentile. Also, early diagnosis is highly correlated with improved outcomes, but the diagnosis in these patients is frequently delayed, and that's because they are frequently getting high-fived for weight loss for the first half to 2/3 of their journey. In addition, we know that physiologic complications in people with prior higher weight are just as severe as people who were in a normal weight category. So meaning if you drop from a higher body weight percentile or BMI percentile to a lower one, even if it's above the 50th percentile, but you've made a big jump, and that's called weight suppression, and I'm going to talk about that in a second, that you can have just as severe medical complications and psychiatric complications as people who lost from the 50th percentile down to the 15th. And in fact, people in this category are often the ones in studies that have the highest percentage weight loss, despite that they present at the 50th percentile, the fastest rate of weight loss, the highest likelihood of a low heart rate, the highest likelihood of changes in blood pressure and pulse from lying to standing, and they're the most likely to require medical admission for stabilization. They are also less likely to resume menses and resume them at a higher BMI if they are female and menstruating. And I just want to point out these are criteria for severe malnutrition developed by dietitians, and published widely. If you notice, really only two, so you can consider severe malnutrition as a diagnosis if any of the following are present. And this is just to point out that only the top two require someone to be at a low BMI. Otherwise, you can be anywhere on a growth curve, but the point is, how much have you lost? And again, what is your degree of weight suppression? I also want to just point out, we're not going to get into a lot of detail on males or trans or gender diverse patients today, but for both of these categories of patients, they are both more likely to be in a larger body prior to the development of their eating disorder. And so that's true of sexual minority and gender diverse youth as well. So it becomes really important to set a high bar in order to achieve a full remission. We now, when I was first trained, we didn't think people could recover fully. It was a win simply to have people, and again, this is back in the 1990s, it was a huge win to have someone go to college for a year or to ever have children or things like that. And no one was conceptualizing people recovering from anorexia nervosa or bulimia nervosa in terms of in a full recovery, a robust recovery. That was not something that we in pediatrics, at least, really were taught. And that altered our lens on things because, of course, if you think that someone can't fully recover, then you're not pushing as hard and you're not shooting as hard and your bar is lower. And so now with the information that we have where we know people can reach a full, robust recovery and get back to their lives, the sooner and the more effectively we intervene, and again, it's not absolutely everyone, but many can, then we really want to shoot for full physical recovery, full pubertal recovery, and a full cognitive recovery. And this becomes important because research that has come out of the parent community, actually run by Dr. Mulheim and Dr. Curso and Dr. LeBeau, who are all, I think, many of them are presenting today. We know that cognitive recovery comes at, in their studies, 6 to 7 pounds above where someone achieves physical recovery. Clinically, I find it often occurs about 10 pounds above for most patients. So you just don't want to undershoot the goal weight, and you want to make sure, because it's the biggest predictor of a full recovery. And you want to make sure that you are, before you consider someone recovered, you're stepping back. You're not just saying, oh, have they gotten to the original target weight that I set 6 months ago? But are they really fully physically, pubertally, and cognitively recovered? And if they are, okay, then you're in a goal weight range. But if they're not, you might need more weight. That is a possibility. Then I like to remind people that once you achieve recovery, you have to protect recovery. And I've sort of gone through this, but a good goal weight is the biggest protective factor against relapse. And reaching your target weight is necessary for pubertal resumption, for optimal brain function, and for reversing medical complications. And we worry that if you don't pick an accurate goal, that you may sort of doom someone to not remit from their illness. This became clear, and there was a case series of young patients with atypical anorexia, which is basically just anorexia in a larger body. And I don't need to get into a lot of work on very prominent researchers, and they did they published on how they did with a full course of adherent FBT, or what was considered to be adherent FBT. However, during the study period, so these patients all presented at around 105% of a median BMI, meaning they were right around the 50th percentile. And again, they had lost a lot of weight from a higher percentile, but they were right at the 50th percentile. And during the study period, as you see here, there were no explicit guidelines provided to clinicians within the service for setting target weights for adolescents with atypical AN. And findings suggest that this approach tended toward weight stabilization, which is a deviation from the distinct focus on weight restoration and FBT for adolescents with AN. And so without guidance, the clinicians felt most comfortable keeping them around the 50th percentile. And unfortunately, only a fewer than 50% remitted, and nearly 40% still met criteria for significant eating disorders at the end of treatment. Which brings us to, why would we do that? Or is it possible that we are denying, one of the biggest part of FBT in the first phase is to weight restore someone to where they used to be. And are we denying larger bodied patients the benefits of weight restoration due to our own bias that, oh gosh, the 50th percentile should be enough? So we also know that patients with atypical anorexia encounter weight bias in practice. There's a lot of variability in terms of the weights and that are set for them. In terms of when they're allowed to exercise, they're often told to exercise far earlier. And parents often have watched their kid be told their whole lives that they need to gain weight and need to lose weight. And so these patients really feel worried about gaining weight, and the parents feel worried about it. And so their fear of weight gain is not just due to anorexia, but also due to weight-based trauma. So we really try with these clients to talk about health and not weight. We're never recommending weight loss as a goal. And we're remembering that people of any size can have a really severe restrictive eating disorder. We're focusing on their behaviors and working on health promoting behaviors, but we're not expecting them to fit into a normal BMI range. And we are setting accurate goal weights that are using historical growth curves. So just getting into that a little, we now recommend that for both adolescents and actually young adults and adults, that we are really trying to think about their lifetime growth trajectory and not just some standard norm off chart. So we're looking at their growth patterns throughout their own lives and considering what pubertal stage they're at, considering if they have catch-up height that's needed, and then remembering that at least for those under 25, there is no such thing as a maintenance weight, which I'll get to in a sec. We try to avoid weight bias and also correct for weight suppression when we set these goal weights. And again, a goal weight really at the end of the day, no matter what we might guess at, is where the physiology, pubertal hormones, and cognitions have normalized. The difference between sort of a partial recovery where you get close to a goal weight like that and a full recovery, a few additional pounds could mean return of menses or return of testosterone function, increased flexibility with eating, less rigidity about exercise, improved mood, less anxiety, and reduced risk of relapse. So a few pounds can make a huge difference. Weight suppression, I mentioned this before, but here's just a pictorial sort of view of it. So you see in the bottom left, that's an excellent example of really significant weight suppression. Someone's BMI was above the 97th and they presented for care at the 10th. That ski jump of a delta between the highest they've ever been and where they present, that's weight suppression. And we are trying to narrow that gap when we get them into treatment and through treatment and beyond. That's because weight suppression is correlated with higher EDEQ and depression scores. It's so eating disorder cognition and depression scores. It also, the more you are weight suppressed at discharge from treatment, the more likely you are to relapse. This has been true in bulimia, in anorexia, in younger and older patients. It is also, as I mentioned before, related to pubertal function and related to medical complications even more than weight or percent target weight. So when you take into account weight suppression, it accounts for many of the complications we see much more than just a raw weight or a raw percentage. This becomes relevant again for people in larger bodies in that here's to the left is someone who has grown at the 50th percentile all their lives, then jumped up right before puberty, right before getting their period, and then went all the way down. And I don't have trouble getting a pediatrician or a parent to understand that that goal weight might at a minimum need to be at the 50th percentile and maybe up to the 75th. However, you can see the same curve to the right here, but just someone who started at a larger body, and people are very uncomfortable having them get, back up from the 50th percentile up to somewhere around the 85th or 90th. That makes people highly uncomfortable. I also want to talk about catch-up height a little because that is a big bonus when you set a good goal weight for growing kids. And just to put a preface on that, most biological females or natal females can continue to grow taller until 2 to 3 years after they get their period. Their height velocity, so the speed at which they grow taller, is the highest the year before they get their period, but they can continue to grow taller up until 2 to 3 years after. So their growth plates don't close until that time. And so we can achieve catch-up growth during that time. Males can usually, not all males, but most of them, their growth plates don't close until late high school or even in college. So they can catch up anytime. So you can see here, this is a 9-year-old female who was premenarchal, And her mom thought she was always meant to be small. Her dad respectfully disagreed. We got old growth curves that showed that she had certainly always grown prior to developing anorexia, that she had always grown between the 50th and 75th percentiles BMI for age. And we aimed for that when we were having her go through treatment. We didn't know how much taller she would grow, but we knew that she started off at around the 25th percentile. And actually her parents, when you plug in their height and think about where genetically she might be able to get to, they were likely to get to what we call a mid-parental height, or projected height, that she would at least reach like the 40th percentile. But here you see here over the next 18 months, she was able to go from the 25th to the 75th percentile for height, just keeping her BMI in between the 50th and 75th. So it made a huge difference for her. We also had a 14-year-old female who'd been ill since she was 7 or 8 and had not grown taller in that whole time. And she came from very tall parents. You can see in the bubble to the right on the height curve to the right that her parents were around the 95th percentile for height. So was her sister. And even though she was 14, she had never had a period. And when we got her BMI up to closer to the 75th percentile, which was where she was when she was very young, because we hadn't, we couldn't consider the last 6 years since she had been sick. She was able to catch up to the 75th over 2 years. And then actually before college, she got to the 90th. So that was huge. I like to remind everyone that we have to protect recovery then. There is no such thing as a maintenance weight, and this is just between the ages of 10 to 16. But you can see here that girls are supposed to gain between like 47 and 57 pounds between 10 and 16, guys between 63 and 80 pounds. And their stature is also undergoing tremendous change. These are times of tremendous change. And between 16 and 26, both guys and girls, and again, I'm being binary with my genders here, which isn't, but really all genders are absolutely able to gain weight, and because they are supposed to, even though they're not growing taller in that time, typically, they are still gaining mass. Their body is supposed to still lay down bone mass, lean muscle mass, fat mass, brain mass, cardiac mass, everything until their mid-20s or even mid to late 20s. And all that mass, it can't happen without weight. So you are not meant to weigh the same that you did when you were 15, when you're 25. So I say this because we have to really account for, like, you get someone to a target weight and then you have to keep going. You have to keep supporting them. In order to do this, you have to feed them enough calories. So that is often 3,000 to 6,000 calories a day, and 2 to 5 pounds of weight gain per week while you're restoring their weight. And understand that people's metabolism is often hyper metabolic, so they burn more energy than their same age, same activity peers. For about 2 years after getting to a healthy weight. So these are not just, oh, let's eat a little bit more until you get to your target weight. Once you get to your target weight, then you're probably going to get back into your life. You're going to be doing more, and you're probably going to need more for quite a while. So their body will tell you when they don't need as much nutrition, but until their body tells you that, it needs a lot. We always want to feed what they need. We want to remember that all types of movement burn calories, that people of higher weights require more calories, not fewer calories. And this is just to reassure people. Sometimes they are really worried that with trying to push faster weight gain earlier in treatment, that it will be so distressing to their children that it's not worth it, that they should go slower. And we used to think that we should have people gain weight at around 1 to 2 pounds a week, or even half a pound to 1 pound. But the problem is that when someone has 40 pounds to gain, if you're doing half a pound a week, then that's going to be 80 weeks. And that is years. And then by the time you get there, they're still supposed to weigh more. So you're just never going to get there, and you're going to fatigue, and the patient will fatigue. So this is to show you that these time points are, I wish they were in the left column, but basically this is 1 month and 3 months of care. So you can see that people were rate restored pretty rapidly. On average, by 3 months, they were in a normal BMI range. and also at a normal goal weight range. And their global and restraint eating disorder scores went way down during that time and then continued to go down over the next 6 months. And their depression anxiety scores also went down to normal before 3 months and then kept going down. That's really important information for parents who worry about this. That doesn't mean that they were excited about this work. And it doesn't mean that there was no overt distress expressed, but over time, their scores got less and less. So you want to maintain a compassionate but straightforward approach to anxiety about goal weights and not bargain on them. Don't offer a lower weight just to ease distress or say like, well, let's just get here and then see what happens. Because you can't unsay a lower weight to someone who cares about weight, and people with eating disorders care about their target weights. So you just need to sort of be honest that we're going to be aiming for whatever you need to be truly well. And model tolerating that distress. I like to remind people that talking about behavior doesn't change behavior. You have to do the behavior to change behavior. And it usually is harder before it's easier. And if there's no anxiety, usually that means we're not challenging the eating disorder enough. So we really don't want to just request or ask people to do what we're asking. We just need to be very calm and clear that this is required. We also don't want to get so excited when people are doing better but are not well, that we end treatment early, or like when we're 90% to the finish line. This is a brief case example in our last few minutes before questions of Jane, who's a 16-year-old female. And I want to be clear that even though I'm using patients with higher weights as examples here, but this is true about goal weights, period. Like even if you've never been in a higher weight percentile, you will have a goal weight range, and we need to aim for the upper end of that range. And if they're not doing well, we need to keep going. And that is still true no matter where your body has been. So Jane was a 16-year-old female, bright, creative, innovative kid, struggled socially, but had several friends now and lived with mom, dad, and an older sibling. This is Jane's growth curve from a weight perspective. And you see that Jane earlier in life was around the 50th to 90th percentile. And then right before she got her period, got above the 90th, and then kept, was sort of going up. And she got her first period here. And then she got an eating disorder. She went up further, and then she got an eating disorder and dropped. And it took a little while for her pediatrician to be concerned. So she dropped, and initially the pediatrician, while expressing a little bit of worry, was mostly happy she had lost weight. And it took so she had lost 85 pounds over 2 years by age 15. But it took until the following year where really she was recognized to have anorexia, even though there were many signs before that mom and dad were bringing to the table. The red line here is just her BMI curve, same kind of curve as what you saw for the weight, but that BMI dropped from 34 to 14, and that is a textbook example of extreme weight suppression. And if you look at the 50th percentile line, that was just a little bit above where she presented at. And that's where many people want to set goal weights for everyone, for no great reason, because not everyone's meant to be the 50th percentile. And Jane certainly was not. She didn't even get her period back until she was close to the 75th percentile. But then she also didn't get cognitive recovery until she was closer to the 90th percentile. Which is where you see the end of the line growth curve there. So because of her previously higher weight, her weight loss was initially supported by her family, but definitely by her PCP. It was positively reinforced by improved peer relationships and decreased bullying. And despite having lots of physical and psychological symptoms when she was 15, an eating disorder diagnosis was not really considered until she was 16. And that weight bias, first of all, put her at risk for an extra year of an eating disorder, but also can result in a goal weight that's too low. So I just want to be clear that when we're treating patients of any weight, but certainly with atypical anorexia, these are eminently treatable illnesses if we intervene early, that there are many barriers to care and blind spots in diagnosis. Caregivers are critical allies. You guys are, most of you are caregivers, but we all need to examine our weight bias when we're setting goal weights. And we want everyone to know that they're supposed to occupy space and not to encourage them to become smaller in size. Um, and this is a great slide from F.E.A.S.T, where recovery is individual to the patient and loved ones know it when they see it. And that's really what I try to recommend with families, that you just keep going until you know your kid is back. Thank you. I have also included here some great videos that I really like on poodle science, which talks about how different dog breeds need different health recommendations and weights and sizes, and is a great example of how we need to think of people too. And then setting goal weights, Eva Musby has a very thoughtful video on how to set goal weights. She uses weight curves. I don't mind using weight curves, but I don't achieve the same kind of catch-up height as when I use BMI curves and projected heights. But the bottom line is that everything on that video is spot on in terms of the conceptuality of it. And then for those of you who live in other countries and whose pediatricians may not collect growth charts, there is a website called mygrowthcharts.com where you can do that for free and track your own children's growth. And that's it. And I want to check on the chat here.
Notice that if you want to go back to that references, the first one with articles, there are a few questions in the chat about resources that can be given to clinicians that are
Yes.
hesitant to set goal weights that are high enough, and how to advocate for the loved one with those clinicians. Are there, I see that you have these, are there any additional ones that you can recommend?
So the Eating Disorder Medical Care Standards Guide, which is the purple book that the Academy of Eating Disorders puts out, I think does have some language that's helpful and digestible for physicians. I have not found a great handout for periods. I mean, excuse me, I'm looking at a question for goal weights for clinicians, and we are actually working on one ourselves. So I wish I had an excellent reference for you that you could hand to your pediatrician, but what you can say, Lauren Mulheim's and Erin Accurso, Accurso, and I can send that out separately. Their article really does show that parents saw recovery at weights that were higher than just physical recovery. And I think that's really important. I am looking at these chats and I'm having a little trouble, Millie, seeing all of these, but hold on, I just opened up the chat box.
Yeah, there is quite a lot in here. A couple people have asked about sharing the target weight with the individual in recovery. Is that a safe thing to do? Is it recommended?
So I'm looking here. Is there a risk of making goals too high that it will make patient resist treatment more? So I addressed that with the research that we showed. It actually makes people less restrictive and less engaged in their eating disorder and their anxiety and depression to make the weight goals consistent with their prior trajectory. And you can feel confident that as long as you stay calm and firm and model that and model the resilience for your kid, that they will be able to get through this, that they will be fine. I'm looking here. Millie, can you repeat the question you found?
Yes, about actually sharing what that goal weight is with the patient or weight range. Is that a safe thing to do?
So all of the FBT literature advocates sharing. I think that I have evolved to, so certainly there's very good research that sharing goal weights is ultimately a good thing for people undergoing treatment. However, I do think that there's a time and a place, and some people have been through extreme weight-related trauma in physicians or clinicians' offices. And so I believe in an approach where you talk to people about, hey, you want to know your goal weight? Happy to discuss that with you. I don't want to act like we can't discuss it, because that sort of implies that you can't tolerate it, and I think you can. However, I also want to do it when you're ready. And if parents are really concerned that it's a bad time for their kid and that they can't handle it right then, I'm willing to wait to discuss it. I think when if if so I don't think it's a one size fits all thing. I think that ultimately, I do think people usually need to know their weight range at some point in their recovery, because they're going to step on a scale, and I want them to be prepared for that. And I'd rather have them be more mindfully prepared for that in a clinician's office and with their family than just do it when they get to college or in a drugstore. So I think so I think that people need to know, and I think it's just a question of when is the best. And that is where I really do want to talk with the kids and the parents and see what makes the most sense. If patients are saying, I have to know, I have to know, I have to know, but it's very clear that they are very honest that if they hear a number that they can't handle, they're going to stop eating, then that's probably not a time to talk to them about it. I'm looking at these questions. There's definitely a sort of a theme of people being at a higher weight and now at a lower weight. And is that okay? And again, I would go back to, are they fully recovered? Because this is the biggest predictor of full recovery, and shortchanging their goal weight is likely to be harmful to them in the long term. So if they are truly fully recovered, for the person whose kids were in the 97th percentile all their life and now they're 88 to 90th and the team feels comfortable, I would challenge the parent to think about, are your kids back? Not are they physically recovered, because they probably are then, but are they cognitively recovered? Are they able to eat freely and flexibly? Can they go to birthday parties and eat cake? Can they do what they need to do? Do they understand that they need to eat more in certain situations? Are they totally focused on this all the time? Then they probably need more weight, and the team needs to get comfortable with that concept. And you're the person that would advocate for that. And someone being at the 90th and now at the 40th really feels like that's still very weight suppressed, and I would be worried about that. But again, if someone is perfectly healthy at the 88th and I predicted the 97th, then I'm not robotically making them march up, but I want them to be fully healthy, and then I want them to stay along that curve. So I think the biggest mistake people can make is trying to have them maintain, and that there is no maintaining weight in the adolescent and young adult years. So they need to keep going up. If they weigh something one year, they should weigh more the following year, and that's just the way growth works. I think that choosing a treatment team is really important, and being clear that if they can't get on board with the goal weights, that then you just don't want them to talk about them with your kids, is at a bare minimum, is important. But I also would really try to find people who can get on board, because it's really undermining for parents. I'm looking here. We
A
don't
couple
use,
questions
yeah.
about menstrual pubertal restoration. Is a period a really good marker of whether someone is at an adequate weight, or is that
So remember the literature that came out that found that on average, most patients need to weigh at least 7 pounds above where they got their periods back. So that generally speaking, like, cardiac stability occurs at one sort of weight range, then pubertal, and that means hormones and periods and testosterone, all of that is the next to occur. And then that does not, usually cognitive recovery is above that by usually 6 to 10 pounds. So I do not think just getting your period back is adequate, no. And so while pubertal recovery is a marker, it's a good marker of pubertal recovery, but it's not a marker of cognitive recovery.
we are at time?
Yep.
So I will let everyone know that the recording and all of the slides will be available for you this coming Wednesday. So you will have these reference lists that you can share with your clinicians. And we thank you for attending this talk, and Dr. Peebles, thank you for speaking to us today.
Thank you so much, everyone. And feel free to email me with any other questions. I'll do my absolute best to respond. Thanks.